Adrenal disorders in children, pathophysiology. Cholesterol, S star, cholesterol. This is the outer mitochondrial membrane and this is the inner mitochondrial membrane. Steroidogenesis, synthesis of glucocorticoids, androgen steroids regulated by adrenocortical trophic hormone, mineralocorticoids, aldosterone regulated by intravascular volume, plasma, potassium, renin, angiotensin, aldosterone system. Steroidogenesis happens from cholesterol, glucocorticoids, androgen steroids, mineralocorticoids, aldosterone regulated by ACTH and regulated by intravascular volume, plasma, potassium, renin, angiotensin, aldosterone system. S star is steroidogenic acute regulatory protein, ACTH, adrenocorticotropic hormones. Cushing syndrome, increased glucocorticoids. Etiology, increased glucocorticoid levels. Endogenous cause, increased production within body. Exogenous cause, most common external source of steroids like drugs. Endogenous causes increased production within the body for steroids. Adrenocorticotropic hormone independent due to adrenal pathology, usually in a young child. ACTH independent due to adrenal pathology, usually in a young child. So, what are the tumors? Adenoma and carcinoma. Adrenocortico hormone development, ACH development, pituitary source, usually in older children, adolescents, like microadenoma, Cushing disease. Ectopic source from tumor rare, neuroblastoma most common, Wilms tumor and carcinoid. Clinical feature increased fat deposition, increased glucocorticoids, no lipolysis and so fat deposition. Manifestations: moon faces, abdominal obesity, stria, buffalo hump due to excessive stretching of skin. Hypertension, intrinsic mineralocorticoid activity of some glucocorticoid. Hypertension, intrinsic mineralocorticoid activity of some glucocorticoid. Hirsutism, overstimulation of adrenal gland. Increased production of androgens in ACTH dependent conditions. Hirsutism, overstimulation of adrenal glands, increased production of androgens in ACTH dependent conditions. Delayed puberty, cortisol inhibits gonadotropin production. Delayed puberty, cortisol inhibits gonadotropin production. Proximal muscle weakness like shoulders and hips. Short stature, slowing of growth. Investigation, screening, 24-hour urine-free cortisol level. Overnight dexamethasone suppression test. Single dose dexamethasone at night. If Cushing syndrome, then increase cortisol levels next morning, unable to suppress. If normal, decrease cortisol in morning due to suppression by dexamethasone. That is called overnight dexamethasone suppression test. Diagnosis, low dose dexamethasone suppression test. So 5 microgram per kg of dexamethasone 6 times a day for 2 days. Cushing syndrome will be increased cortisol level. ACTH estimation in picogram per mils to differentiate based on ACTH dependence. So for screening you are giving overnight dexamethasone test, and for diagnosis you are giving low dose dexamethasone suppression test. ACTH estimation in picogram per mil to differentiate based on 5 microgram per kg of dexamethasone 6 times a day for 2 days. If Cushing syndrome, then the cortisol level will be increased, followed by ACTH estimation in picogram per minute to differentiate based on ACTH dependence. Low. So diagnosis: low dose dexamethasone suppression test 5 microgram per kg of dexamethasone 6 times a day for 2 days. If there is Cushing syndrome, then cortisol level will increase. It will not be able to suppress the cortisol level, and then you do adrenocorticotropic hormone estimations to differentiate whether it is adrenocorticotropic hormone dependent or not. If it is low, that it is less than 15, then it is adrenocorticotropic hormone dependent. If it is high, pituitary source is more than 15, then and it could be very high, that ACTH is less than 100. In that, you are suspecting ectopic tumor which is releasing adrenocorticotropic hormone, and in high source more than 15, you are suspecting pituitary source. So high dose dexamethasone suppression test, pituitary source will be suppressed, but tumor producing ACTH will not be suppressed. Treatment: surgical resection of identified tumor, Cushing's disease, transsphenoidal resection, surgical resection of identified tumor, Cushing's disease, transsphenoidal resection. Medical, also known as medical adrenalectomy, also known as medical adrenalectomy. Medical inhibition of adrenal steroidogenesis by antifungals. Medical inhibitions of adrenal steroidogenesis by antifungals like ketoconazole or metirapone or metotane. Ketoconazole, metirapone or metotane, also known as medical adrenalectomy. Antifungals are used. Congenital adrenal hyperplasia. Most common adrenal disorder in childhood is congenital adrenal hyperplasia. Mode of inheritance: autosomal recessive. Pathophysiology: decreased enzyme, decreased steroid, glucocorticoid, feedback to pituitary gland. So increase ACTH, tropic action, adrenal gland hyperplasia. Deficiency of enzymes: most common is 21 hydroxylase. Most common deficiency of enzyme is 21 hydroxylase. 21 hydroxylase deficiency: decrease enzyme, decrease aldosterone, decrease cortisol, feedback increase ACTH, positive feedback to increase androgen production due to enzyme deficiency. This is due to enzyme deficiency, you have increased androgen. Clinical features: low aldosterone, high androgens, and high ACTH. Low aldosterone: because of low aldosterone, there is less BP, low BP, and there could be shock. In renal tubules, hyponatremia, salt wasting in urine, hyperkalemia due to decreased resorption, hyperkalemia. High androgens in males and in females. In males, it can cause precocious puberty. In females, it causes ambiguous genitalia and clitoromegaly. High ACTH also acts on melanocyte stimulating hormone MSH receptor due to similar structure, and there is higher pigmentation. Management: newborn screening, estimation of 17 hydroxyprogesterone levels. How do you do newborn screening for congenital adrenal hyperplasia? You screen for the enzyme 17 hydroxyprogesterone. 17 hydroxyprogesterone levels. Lifelong replacement of aldosterone with fluorocortisone and cortisone with hydrocortisone. Aldosterone with fluorocortisone and cortisol with hydrocortisone. Dose adjustment during stress due to increased requirement. Dose adjustment during stress due to increased requirement. Minor stress 2x to 3x dose infection. Major stress 4x to 5x dose surgeries. Minor stress 2x to 3x dose in infections. Major stress 4x to 5x dose surgeries. Surgical correction of ambiguous genitalia should be done within 2 to 6 months. Surgical correction of ambiguous genitalia should be done within 2 to 6 months. Clitoroplasty. 11 beta hydroxylase deficiency. 11 beta hydroxylase deficiency. Decreased enzyme. Decreased aldosterone. Decreased cortisol. Due to enzyme deficiency, increased adrenocorticotropic hormone produces androgens. Clinical features: high androgens, precocious puberty and ambiguous genitalia in female, high ACTH, adrenocorticotropic hormone, hyperpigmentation, high 2-deoxycorticosterone, mineralocorticoid action, hypertension in spite of decreased aldosterone. So because of high 2-deoxycorticosterone, mineralocorticoid action, hypertension in spite of decreased aldosterone. 17 alpha hydroxylase deficiency. Decreased enzyme, decreased cortisol, increased adrenocorticotropic hormone, positive feedback, and increased aldosterone. Plus decreased testosterone, aldosterone pathway unaffected. Clinical features: high aldosterone, hypertension. Clinical features: because of high aldosterone, there is hypertension, low androgens in males under virilization, hypospadias, bifid scrotum, delayed puberty. In severe cases, ambiguous genitalia. In females, usually asymptomatic, slow delayed progression of puberty due to decreased aromatization of testosterone and decreased estradiol, high ACTH, hyperpigmentation. There was a girl in the OPD where she always had very high blood pressure, like above 100 diastolic all the time, and she was very young, and we were suspecting this congenital adrenal hyperplasia in her. 3 beta HSD deficiency. Decreased enzyme. 3 beta HSD deficiency. Decreased enzyme, decreased cortisol, decreased aldosterone, decreased androgens, increased ACTH. Clinical features: low aldosterone, decreased BP, plus hyponatremia, plus hyperkalemia, high ACTH, hyperpigmentation, low androgens in male under virilization. In females, mild virilization due to increased dehydroepiandrosterone, mild androgen in older child. Features: acne, hirsutism, menstrual irregularities. Pointers for diagnosis: serum androgen. Salt wasting feature. Salt wasting feature is present in increased 21 hydroxy deficiency. Salt wasting feature and serum androgen. Serum androgen is increased in 21 hydroxy deficiency and 11 beta hydroxy deficiency. Serum androgen is increased, but in 21 hydroxy deficiency you see salt wasting features as well. Then serum androgen is decreased in 3 beta HSD deficiency and 17 alpha hydroxy deficiency, but salt wasting feature is only seen in 3 beta HSD deficiency. In the next video we will see pubertal disorders.